Hello everyone, very good evening to all of you. I hope I am audible and visible to you. You all can hear me. You all can hear me? Yes, hello. Very good evening to all of you. You all can hear me and you can see me. Right. Yes, this will stay on YouTube. Amber, this will stay on YouTube. Good evening, Keval. Good evening to all of you. Good evening, microarray, microarray one. Very good evening to all of you. This will stay on YouTube. All the lectures will be present in my YouTube live session. So, as many of students have requested me to conduct the lecture on the GIT polyp, so I have tried my best effort to bring this GIT polyp, and I try to integrate the clinical scenarios also, which can be asked in your exam, right? So let's start. I will be giving you some question also. I will be having some discussion also. So as you can see, the name itself is telling that it is a polyp, right? So as you can see, the name itself is about polyp. So first of all, we should know what is the polyp. So whenever we think about GIT polyps, so remember what is GIT polyp. These are simply a mass, right? So what are these things? These are the mass which is protruding into the gut lumen. Remember, any mass which is protruding into the gut lumen should be considered as polyp, right? Now we have to understand, polyp can be true also, polyp can be pseudo also. True polyp, when they will have all four layers. All four layers means mucosa, submucosa, right? Muscularis propria, and then serosa or adventitia. So all four layers are present. So this will be true polyp, right? But when you find only mucosa or submucosa, so that will be called as pseudo polyp. Can you tell me any example of pseudo polyp? Can you tell me any example of pseudo polyp? Any of you? Any example of the pseudo polyp? Can you tell me? Can you tell me what is the pseudo polyp example? Yes. Very good. Ulcerative colitis. So one of the great example is the ulcerative colitis, right? So ulcerative colitis, Crohn's disease, these disorders will be having pseudo polyp because they will have mucosal damage, and now mucosa will regenerate to form the polyp. That is the pseudo polyp, right? So this is the basic introduction about the pseudo polyp and polyp. Now the next thing which I want to show you, the classification of the GI polyps. This is the very old classification. Just for the purpose of understanding, I am showing you this thing, right? What I want to show you, we can divide GI polyp into the I will say into the three categories. Non-neoplastic polyp, you include only these two, right? Inflammatory polyp and hyperplastic polyp, right? So non-neoplastic, neoplastic, and familial polyposis syndrome. So these are the three group of the GI polyp which we are going to cover today, right? I will start MCQ also, don't worry, right? So it will be very kind of fun kind of thing. You will enjoy this lecture, don't worry, right? So now as I said, there are three things, right? Non-neoplastic, neoplastic, and familial polyposis, right? In non-neoplastic, I said there is a inflammatory and hyperplastic, right? Neoplastic polyp, you can include hamartomatous also. See, I will tell you why these group of polyp, right? Now you can see this group of polyp: juvenile polyp, juvenile polyposis syndrome, Jagger syndrome, Cowden syndrome, Cronkite Canada syndrome, right? They are initially considered as hamartomatous and they are not associated with the tumor. But later on, it was found out that they can be associated with the tumor also. So that is why I am saying now this should be considered under the heading of neoplastic polyp, right? Neoplastic hamartomatous polyp, right? So so now you can see that these are the important thing: non-neoplastic polyps, inflammatory, hyperplastic. They can be risk also, right? There is slight risk, but mostly they are considered as non-neoplastic, right? Hamartomatous polyp, what are the examples we have to remember? In hamartomatous polyp, we have to remember, as I said, juvenile polyp, juvenile polyposis syndrome, Jagger syndrome, Cowden syndrome, remember Cowden syndrome, and Benign syndrome. And last is the Cronkite Canada syndrome. So these are all hamartomatous. So please remember, in hamartomatous we are having all these 5 names: juvenile polyposis, juvenile polyp, Jagger, Cowden, Benign and Cronkite Canada syndrome. When we talk about neoplastic, in neoplastic we are going to discuss about 3 important, right? Tubular adenoma, villus adenoma, and tubulo-villus adenoma. So tubular, villus, tubule like tubular, finger like villi, and tubule and finger both like tubulo-villus, right? So these are the neoplastic adenomas, right? So these are also called as neoplastic adenomas. Then familial, some polyposis are familial, and they are called as familial adenomatous polyposis syndrome. So familial adenomatous polyposis syndrome will be having 2 important association. One is Gardner syndrome and second is the Turquod syndrome. So remember, familial adenomatous polyposis is associated with Gardner syndrome and Turquod syndrome, right? And the 4th one is the malignant tumor of the colon, which is also called as hereditary non-polyposis colorectal carcinoma, right? So this is just familial polyposis, so that's why I have written here. So these are the important things. So let's start the question number 1. A 55-year-old male with abdominal pain was analyzed and found to be having polypoidal lesion. Biopsy was taken and histopathological examination is given below in this image. Which of the following is the most likely diagnosis? So what is the most likely diagnosis? Now I will be waiting for your answer. Don't worry, I am going to go in detail of all the things. I'm going to cover all the things, don't worry. Right, so you tell me what is the right answer for this question. Right, to see. First correct answer I have got it from the student called Manu. Manu has given me the first correct answer, and this is the hyperplastic polyp. So Manu, then Piyush. So answer is B. See, this question, a 55-year-old abdominal pain, right? Polypoidal lesion. Biopsy was taken, and this biopsy is very characteristic. What is characteristic in this biopsy? If you look at the biopsy, you can see there is a hyperplasia, right? So here you can see there is a hyperplasia of the intestinal epithelial cell. So there is an increase in epithelial cell which is containing goblet. So you can see there is a mucin containing goblet cells. Can you notice? Can you appreciate this mucin containing goblet cells? So these are the mucin containing goblet cells, right? So there is an increase in epithelial cell which is containing goblet cell, and because of this increase in epithelial cell, if you notice, how is the lumen? Lumen is now looking serrated, right? So because of epithelial cell hyperplasia, there will be a serrated architecture, right? There will be a serrated architecture. So remember, this is very, very important. Whenever you find hyperplastic epithelium, right, sawtooth appearance or serrated appearance. So you can also call this as a sawtooth or serrated appearance. So sawtooth serrated appearance is diagnostic of hyperplastic polyp, right? So please remember, this is the hyperplastic polyp which you have to understand, right? So this is not tubular polyp. Tubular polyp will be having tubule-like structure. Tubulovillus will be having tubule and villi-like structure, which I will explain you later on, right? And villus will be having finger-like villi. So all these things we are going to discuss. So this was a very clean question. This question came in AIMS 2016 also, right? So whenever you find this kind of polyp, that is the hyperplastic polyp, right? So I'm going to explain also, don't worry. So this is how you have to understand hyperplastic polyp. Whenever you analyze, these are commonly seen in the age group of 60 to 70 years. their most common site. If you look at the most common site for hyperplastic polyp, so your answer should be rectosigmoid colon, right? So rectosigmoid colon is the most common site, right? In this question also you can see there was a abdominal pain and this site was not mentioned, right? So site was not mentioned here, so no issue, but examiner can give you the site also. So rectosigmoid colon is the most common site. What is the problem in hyperplastic polyp? There will be increased proliferation of glandular epithelial cells. So you remember there was a glandular epithelial cell which were containing goblets, right? So goblet cells, these are actually goblet cells which are having hyperplasia. And see, there are two things. One, there is a more proliferation of the epithelium, right? More proliferation of the epithelium and delayed shedding. So this delayed shedding, so one side there is a more proliferation. Usually epithelium will be proliferating and then they will be shedded away, but they are getting proliferation and there is no shedding, so they will accumulate. And because of this accumulation, when you are going to see inside the lumen, right, you are going to see inside the lumen. So now you can see there is a irregular proliferation going on, so they are going to form a serrated or sawtooth appearance, right? So overcrowding of the glands, this will be the reason for the serrated appearance, and there is no malignant potential for the hyperplastic polyp, right? So hyperplastic polyp, they have no malignant. So now you can see this is the important point. Now you can see these are all epithelial cells, right? These are all epithelial cell, and you are noticing there is a hyperplasia of the epithelial cell, and because of this hyperplasia there is a irregular serrated surface of the gland will be formed, and this is considered as hallmark. So now you understood, this is the hallmark of hyperplastic polyp. So everybody understood? So there will be more hyperplasia, less shedding, and that will create overcrowding. And because of the overcrowding, now you can see there is a more hyperplasia of the epithelial cell, right? The more hyperplasia of the epithelial cell, and now you can see the lumen is looking serrated. And now you can see whenever you find serrated margin, so that will be, right, that will be diagnostic for the hyperplastic polyp, right? Now come to the picture. Now you can see this diagram which I have shown you. In this you can notice these are the goblet cells which is showing you hyperplasia, and these are the areas showing you serrated architecture, right? So now you can notice there is a serrated architecture which you can see here, right? So here you can notice there is a serrated architecture, right? Here you can see serrated architecture is present, right? So this serrated architecture is because of the hyperplasia. So that is the hyperplastic polyp, right? Now come to the next one. A 5-year-old boy came with the rectal mass. Histopathology from mass is given below. So now you can see this is the histopathology of the mass, right? Which of the following is true statement about this is lesion? Mutation in P10, SMAT4, associated with polyp and mucocutaneous hyperpigmentation. Biopsy will be showing you serrated architecture. See, this question is very sharp MCQ, right? So first answer is given by microarray 1. First correct answer I have got from the student called microarray 1, right? So this is a 5-year-old boy, rectal mass. You should think about juvenile polyp, right? You should think about juvenile polyp, right? Juvenile polyp. And when you see this kind of appearance, what is this appearance? Can you see there are so many tiny glands are there? All these are tiny glands. So there is a hyperplasia of the gland, right? So what I'm showing you here, this is hyperplastic gland, right? So we are seeing hyperplastic glands. So hyperplastic glands are there, and you can see there is a one very good stalk. This is the one stalk of the tissue, right? So there is a one stalk of the tissue. Now you can notice that this is not penetrating into the gland, right? They are not penetrating into the gland. That is how it is discriminated from the Peutz-Jeghers syndrome, because some of you have given answer as a Peutz-Jeghers syndrome, right? So that is why juvenile polyp on microscopic examination, they are having a close differential, that is Peutz-Jeghers syndrome. But remember, in Peutz-Jeghers syndrome, when I will explain you, that time I will show you also, you will see hyperplastic gland, but between these hyperplastic gland you are going to see the intersection of the smooth muscle. Here you are not seeing intersection of the smooth muscle. Here you are seeing only hyperplastic glands like this, right? Hyperplastic dilated glands are present like this, and there is a one stalk here. That's all. There is a one stalk here. That's all. So this is like this, right? So now you understood. So this is not a Peutz-Jeghers polyp. This is the juvenile polyp, right? Juvenile polyp, rectal mass. What is the mutation you are going to see? So remember, in juvenile polyp, most common mutation is mutation in SMAD4 gene. So that was also NEETPG question. So just remember, SMAD4 mutation is the most common mutation seen in the juvenile polyp. P10 mutation will be seen in which disorder? So here we have to remember, P10 mutation will be seen in P10 mutation will be seen in which disorder? So P10 mutation will be seen in the Cowden syndrome, right? So this will be seen in Cowden syndrome, right? So this will be seen in Cowden syndrome, right? So associated with polyp and mucocutaneous hyperpigmentation, this is the Peutz-Jeghers syndrome, right? So this will be seen in Peutz-Jeghers syndrome. Biopsy will be showing you serrated architecture. Just now we have seen that will be hyperplastic polyp, right? So this will be seen in hyperplastic polyp. So now you understood, right answer is mutation in SMAD4 gene, right? Now come to the next one. So I will just explain all these things. See, what you should remember, that juvenile polyp is commonly seen in which age group? 5 years, right? Most common site is the rectum. Most commonly associated with which mutation? So now you can see that most commonly is SMAD4, and other mutation is BMPA1, right? So what will happen? Because of this SMAD4 mutation, there is a defective signaling of TGF beta. Because of the defective signaling of the TGF beta, there will be a formation of the polyp. TGF beta is a fibrogenic cytokine, right? And because of the defective signaling, there will be more fibrosis, or fibrogenic cytokine will be more, and that will cause more proliferation of the tissue, and that will lead to the formation of the polyp, right? What is very important to understand, juvenile polyp have a no malignant potential. Remember, no malignant transformation will be seen in juvenile polyp, right? And whenever you are going to see juvenile polyp on gross examination, remember, on gross examination, there will be single round mass in the rectum. Solitary round mass in the rectum will be the clinical or gross presentation, right? Microscopic examination, you will see cystically dilated mucosal gland, and they will be having hyperplasia. So cystically dilated mucosal gland hyperplasia will be present, cystically dilated, right? So now you can see that there is a juvenile polyp on endoscopy. So you can see this is the juvenile polyp on colonoscopy. So now you can see this is how it will be given in exam also, right? They will be giving you a colonoscopy of the boy, young boy, 5-year-old boy, and they will be showing you this is the 15 millimeters large specimen. So what is the likely diagnosis if you find this kind of microscopic examination, right? So now you can see there are cystically dilated glands. So now you can notice these are all, right? So these are all cystically dilated glands, right? Cystically dilated glands. So can you see, some are very small, some are very big, very obvious. So now these are all cystically dilated glands which we are seeing here, right? So these are all cystically dilated glands with chronic inflammation, right? This will be suggestive of juvenile polyp, also known as retention polyp, right? So please remember, cystically dilated gland, but there is no intersecting smooth muscles, which you will see in Peutz-Jeghers syndrome, right? So that you will see only in the Peutz-Jeghers syndrome, right? Now the next one is the juvenile polyposis syndrome. See, juvenile polyp, juvenile polyposis syndrome, both are different things. Juvenile polyp was solitary. You remember, they were solitary. But how is this one? There will be more than 100 hamartomatous colonic polyp will be there, right? So when you find more than 100 polyps, right, in a young boy, then you will think about juvenile polyposis syndrome, and they have a risk. They have a risk for the ulceration and bleeding, right? So they will be having risk for the ulceration and bleeding, and they have an increased risk for the colon adenocarcinoma also. So juvenile polyp, you remember, there was no malignant potential, but juvenile polyposis syndrome, there are two things you have to remember. One is colon cancer risk, and second is the extraintestinal, that is the pulmonary arteriovenous malformation. So examiner can ask you more than 100 hamartomatous lesion with pulmonary arteriovenous malformation and colon adenocarcinoma. So diagnosis will be juvenile polyposis syndrome, right? So that is how you will understand juvenile polyposis syndrome, right? Now come to the next question. A 10-year-old boy having abdominal pain and melena from past 2 years, his clinical and radiological examination has revealed the finding consistent with the intussusception. Enterotomy was done and removing nodule from the histopathological lesion is given below, right? Which of the following is most likely to be associated with this condition? So now you can see there is a clinical finding and there is a microscopic finding. So which of the following is correct? Okay, for this question, everybody is not reading the language of the question. Not reading the language of the question. That is very, very important. Aruna has only read this language of the question properly. Only Aruna, now Manasi. So many of you have committed this mistake, right? See, what is diagnosis? You are seeing mucocutaneous hyperpigmentation, right? So these are all mucocutaneous hyperpigmentation. Mucocutaneous hyperpigmentation is present, right? And now in this we are seeing again a hyperplastic gland. So here you can see that what I was telling you. Now you can notice there is a hyperplastic gland, right? So hyperplasia of the gland is there. So you can notice there are so many small glands are visible, right? So small glands are visible. So this is the hyperplasia, and within this hyperplasia, now you can notice there is a, smooth muscles are intersecting between them. Smooth muscles are intersecting. Can you notice these are all smooth muscles, the pink color, right? So all these pink color are smooth muscles are intersecting. So that gives a appearance like a tree. So this is also called as arborization of the smooth muscle. So what I am showing you in this picture, it is also called as arborization of smooth muscles, right? Where, so this arborization of smooth muscle is seen within the smooth muscle is seen within the right. So arborization of smooth muscle is occurring within the hyperplastic glands, right? So this arborization of smooth muscle within the hyperplastic gland is diagnostic of Jagger syndrome, right? This is diagnostic of Jagger syndrome. This is also known as Christmas tree appearance. So sometime it will be also written as a Christmas tree appearance, right? So remember, this is also called as Christmas tree appearance, right? This is also called as Christmas tree appearance. Christmas tree appearance, arborization. And why arborization? Smooth muscles are intersecting between the hyperplastic gland. Remember, what is this? Hyperplastic gland. So their diagnosis is Jagger syndrome. So P10 gene mutation, already I have told you, Cowden syndrome. Mutation in SMAD4 will be seen in juvenile polyp, right? Juvenile polyp. And now you have two kind of mutation, gain or loss. So please remember, Jagger syndrome is due to loss of gene mutation. So please remember, answer is loss of function mutation in the STK11. You all have given, majority of you were knowing it, but you all have given gain of function mutation in STK11, right? Probably might be, you are very in a hurry, you have given your answer. So now you understood. During exam time, you have to read each and every option very carefully. This is how the similar options will be given and you have to choose the correct answer, right? So loss of function mutation in STK11 gene is the reason for the this Peutz-Jeghers syndrome. Everybody, is it clear? Right. So now you can see in Peutz-Jeghers syndrome, right? In Peutz-Jeghers syndrome, mostly it is a pediatric tumor, pediatric polyp, hematomatous polyp. 11 year of the age group will be commonly affected. Mutation will be seen in the LKB1 STK11. So that was the question. If you see this, right? So this will be LKB1 STK11 gene mutation, and that will be loss of function. So that was the main point. So loss of function mutation in the LKB1 STK11 gene will be present in the Peutz-Jeghers polyp, right? What will be the presentation? They will be having GI polyp and mucocutaneous hyperpigmentation. Mucocutaneous hyperpigmentation can be seen in can be reflected as a macule. Remember, they will be reflected as a macule. And where you are going to see this hyperpigmented macule? These hyperpigmented macules are going to be seen in the perioral area, as I have shown you in this question. But that is not only limited to the perioral. They can be seen in the perianal area also, or in the genital area also. So we have seen this kind of case when I was doing my internship. Patient will be coming with the polyp or intussusception, and when you are going to have a general examination, so you may find that there is a perianal or genital macules, hyperpigmented macules with the abdominal pain and intussusception. Think about Peutz-Jeghers syndrome, right? In Peutz-Jeghers syndrome, there will be increased risk of these cancers, right? Pancreas, colon, breast, and thyroid, right? And remember, pancreatic adenocarcinoma is most strongly associated with which polyposis? Most strongly associated with Peutz-Jeghers syndrome. This was the question in the AIMS 2018, right? So this is very, very important, right? So right, so mucocutaneous pigmentation, intussusception is only mentioned, then we cannot say anything, right? Only intussusception, there are so many differential for that thing. Mucocutaneous pigmentation is the catch point, right? After, if mucocutaneous pigmentation is given, then only it will be in favor of the Peutz-Jeghers syndrome. So on gross examination, they will be having bosselated appearance. What do you mean by bosselated appearance? Bosselated means you are going to see one mass, right? See, there is a one office. This mass is like one office, right? And when you see there is only one boss, right? If you find only one boss into this office, that will be called as boss, right? But when you see multiple bosses in the same office, that will be called as bosselated. So now you understood. So there will be a round mass and multiple nodular structures will be present on that mass. That is called as bosselated appearance, right? So gross examination of Peutz-Jeghers syndrome will be having bosselated appearance, right? So they will be having bosselated appearance. And microscopic examination, as I said, there will be arborization. So in this arborization, what we are going to see is smooth muscles. Smooth muscles, and they are going to intersect the hyperplastic glandular epithelium. So when smooth muscles are intersecting within the hyperplastic glandular epithelium, this is the reason for the arborization or Christmas tree appearance. So now you understand, this is the reason for the arborization or Christmas tree appearance, right? So always remember, smooth muscles are intersecting. Where they are intersecting? Within the hyperplastic glands, right? So within the hyperplastic glandular epithelium, right? Now this is the picture which I have shown you in the question also. These are the macules, hyperpigmented macule in the perioral area, that is suggestive of Peutz-Jeghers if you find abdominal pain, right? Now you can see this is the gross finding, right? If you look at this gross finding, right, this is the gross finding. You can see gross finding, and you can notice there are so many small nodules, right? So that is why I said there are multiple bosses. So this will be called as bosselated appearance, right? So bosculated, multiple nodule or multiple growths are present. So bosculated appearance. When we are going to take the section, and now you can notice there are so many gland and their hyperplasia. So these are all glandular hyperplasia, right? Can you see glandular hyperplasia? And in between you can notice smooth muscles are intersecting, right? In between you can see the smooth muscles are intersecting, right? So these are the smooth muscles, right? Intersecting smooth muscle. These are the smooth muscles. So smooth muscles are intersecting, and that is why it overall, if you look, this looks like a Christmas tree appearance. So there is a hyperplastic mucosal epithelium and arborizing bands of smooth muscles are there. That is the arborization, and that will be the Jagger syndrome, right? Which will be having loss of function mutation in the STK11 gene, right? Now look at this question. 21-year-old man presented with abdominal pain. Physical examination is given here. Physical examination and tissue biopsy is revealed the finding below. So this tissue biopsy, I will tell you, this is the skin biopsy. I did not write there, but examiner will be giving you like this. Skin biopsy is given here. Genetic testing was showing hematomatous lesion and they were positive for P10 mutation. Most likely diagnosis will be. So what will be most likely diagnosis? Most likely diagnosis in this condition. See the mouth and nose area, they are showing you characteristic thing. Then there is a skin lesion. So what will be your diagnosis now? Very good. So who is giving right answer? Aryan has given me the first correct answer. That is the Cowden syndrome, right? So this is the Cowden syndrome. See, when you find, see this lesion, that micropapillomas of the skin, what I'm showing you here, these are the micropapillomas of the skin. Or in a very simple manner, if I want to say that, examiner will be giving you benign skin tumor. Benign skin tumor. So benign skin tumor, right? And this type of early cutaneous manifestations, and this is the skin tumor. What is the name of this skin tumor? Can you tell me? Can you tell me? By seeing all these things, there is a palisading in the basal area. Palisading in the basal area. Clear cells are seen. So can you name this skin tumor? Anybody? Can you name this skin tumor? This is tricoloma. Tricoloma, right? So this is tricoloma, right? So this is the tricoloma, which you have to remember, which we are seeing here. I'll explain you all these things. So when you find these combination along with P10 gene mutation, so that will be diagnostic of Cowden syndrome. Jagger syndrome, already we remember STK11, and they will be having hyperpigmented macule, not the papillomas, right? Cronkite Canada syndrome is non-hereditary syndrome, right? Cronkite Canada syndrome is a non-hereditary syndrome, so that is also not the right answer for this, right? Now Gardner syndrome will be having other things, osteomas and all these things will be present in them, right? And they are not positive for this thing. They will be associated with familial adenomatous polyposis. So this is how you can distinguish, and that answer should be Cowden syndrome. See this, multiple white smooth papules are present over the lower lip. You can see these are the papule, and now you can see smaller papules are present here in the nasal area. So mucocutaneous papillomas, right, they are present in Cowden syndrome, and Cowden syndrome, as we all know, that they are autosomal dominant syndrome, right? And it is very important to recognize the oral manifestation. Remember, I am not talking about the MCQ only. I am talking about in your clinical practice also. When you see this kind of presentation, right, and patient is having some abdominal discomfort also, so that will be used for early diagnosis of the condition like a Cowden syndrome, right? So now I understood. So that is why I said ki this is very important to understand the clinical scenario based question and apply in our life also. When we see a patient with abdominal pain, suppose he came with the skin pigmentation like skin papillomas like this, and while talking to him you came to know that, sir, I am having some problem with the abdomen also, sir, I am on off pain will be there, melena is there, or some blood is coming in the stool. So when he is giving this kind of history, you should think about Cowden syndrome, right? That time what you should do, go for the genetic testing, right? So what should be your next step? Go for the genetic testing, because on genetic testing they will be positive for P10 gene mutation, right? So P10 gene mutation will be present on genetic testing, right? Now look at this skin lesion. I have said this is the tricholemoma. So it's a benign skin tumor, right? You are seeing here, you can see there is a papilloma, right? Papillomatosis, there is a hyperkeratosis, right? You can see there is a papillomatosis, then there is a hyperkeratosis. And when you are going to see the high power view, what is the key finding? Key finding is downward growth. Can you see there is a downward growth of the skin lesion, right? And you can notice there is a clear cell differentiation in this area. You can notice there are clear cell differentiation because of the past positive substances, glycogen will be present in them, right? And this is also very important. If you look at this peripheral area, you can notice there is a peripheral palisading also. So basal peripheral palisading can be also present, right? So downward growth of the tumor with basal palisading and clear cells which are at the base, as you can see in this biopsy also, that will be diagnostic of the tricholemoma. So when you find all these things, you should think about Cowden syndrome. Remember, Cowden syndrome and Benign-Ruvalcaba relay syndrome. Nowadays both are combined together and they are considered as a spectrum of the same disorder, right? A spectrum of the same disorder. So why it is called as a spectrum of the same disorder? Because both will be having one gene mutation that is called as P10. So remember, P10 name itself is a one very important hint. P10 chromosome number is 10. Chromosome number is 10. So name itself is telling chromosome 10. So P10 is chromosome number 10. And Cowden Benign-Ruvalcaba syndrome, both will be hamartomatous polyp and both will be having common mutation P10, and their symptoms will be also they will be having like a spectrum of the disorder. So that is why nowadays it is called as P10 hamartomatous tumor syndrome. So then now you can see that also known as P10 hamartomatous tumor syndrome. So what are two tumors? Cowden syndrome and Benign-Ruvalcaba syndrome. So Cowden syndrome, you will see GI polyp. They will have big head, macrocephaly, and benign skin tumor, as I have told you, tricholemoma, right? So tricholemoma, benign skin tumor, micropapilloma, all these things will be present, right? What is the risk of Cowden syndrome, right? See, why we should diagnose, why I said early diagnosis of the skin is very important. Once you came to the diagnosis of the Cowden syndrome, then you can understand they are having increased risk for the malignancy in the breast, thyroid, and endometrium. So remember, breast, thyroid, endometrium, these cancer risk will be also high in the known case of Cowden syndrome, right? So now understood. Benign-Ruvalcaba relay syndrome, they will also have GI polyp, macrocephaly. So now you can see these two things are same. Now they also have benign skin tumor, so that is also same. What is additional point? They will be having more mental retardation and developmental anomalies. So these are the things which will be added up into the Cowden syndrome, and then they will become Benign-Ruvalcaba syndrome, right? So now understood. So both Cowden, Benign-Ruvalcaba, spectrum of the disorder, P10 gene mutation, chromosome 10, GI polyp, macrocephaly, benign skin tumor in both of them, right? Benign-Ruvalcaba will be having more mental retardation and developmental anomalies. Cowden syndrome will be having more malignancy of the breast, thyroid, and endometrium, and here it will be very low chances of all these cancers, right? Now, Cronkite Canada syndrome was also given in the option. So as I said, they do not have any hereditary factor. They are non-hereditary condition, right? And the second thing, their finding will be seen in beyond 50 years. In this patient was young patient, right? So beyond 50 years of the age group, you are going to see Cronkite Canada syndrome. What will be Cronkite Canada syndrome? They will also have GI polyp. They will have hair loss, nail atrophy, and altered skin pigmentation, right? So here you have to remember that hair loss, nail atrophy, altered skin pigmentation along with the GI polyp will be Cronkite Canada syndrome. This is also very important to identify and diagnose early, because more than 50% of the individual, they will die because of the cachexia, right? They will die because of the cachexia. So that is very important point to understand. Cronkite Canada syndrome is a non-hereditary syndrome, right? And the findings you will see like this. So these are the nail dystrophy. You can see here nail dystrophy, right? You can notice. Then you can notice there is a loss of hair, alopecia, right? This is after transplantation, it has become like this. So there is a loss of hair, alopecia, and now you can see cutaneous hyperpigmentation. So cutaneous hyperpigmentation. So nail dystrophy, cutaneous hyperpigmentation, alopecia, and if you see a history of GI polyp on endoscopic examination, right? So remember, this can be a case of Cronkite Canada syndrome, right? What is Cronkite Canada syndrome? It is a non-hereditary polyposis syndrome, right? Now come to the next question. A 65-year-old female undergoes routine colonoscopy. During the procedure, a 2 centimeter mass is identified in the rectosigmoid colon and it was resected. Surgical specimen is showing the image here. Microscopic findings are shown below in this image. So that surgical specimen, that microscopic finding is shown here. So which of the following is most likely diagnosis for this patient's colonic lesion? Now tell me, what should be the right answer? It's a tough question. It's not easy question. But after listening to this explanation, you will understand this was easy question. That is how, GI polyp question will be asked in exam. You look at the gland and you will get the diagnosis. Right. So first correct answer I have got from Nitesh. Nitesh has given the first correct answer, that is the tubular adenoma. 65-year-old female, routine colonoscopy, rectosigmoid region, right? And when you find there are so many, can you see these are all tubule-like gland, tubular form, right? So glands are in tubular form. So these are all tubules, right? Tubules, number one, on microscopic examination. Second thing, if you notice the appearance of the tumor, can you see from this appearance also you can make out there is a mushroom like appearance. So when you see the mushroom like biopsy and appearance na, so that means you are looking at the tubular adenoma. It cannot be, see, adenocarcinoma. Why not adenocarcinoma? Because there is no nuclear overcrowding or hyperchromatic nuclei, right? So why not adenocarcinoma? Why not adenocarcinoma? So for that I will say there is no nuclear overcrowding and there is no hyperchromatic nuclei, right? So there is no hyperchromatism and no overcrowding of the nuclei. No overcrowding of the nuclei, right? Hyperplastic polyp, we all know that already, we have discussed serrated appearance should be present. Now there are two options which are close by, that is tubular and villus. So villus will be having finger like projection. They will be not, they are like tubule. In villus they will be having very thin finger like projection like this, right? So this will be like this. So answer is tubular adenoma. So here I will explain about neoplastic polyp. Most commonly, neoplastic polyp is the adenomas. So remember, most common neoplastic polyp is adenoma. So this tubular villus, all these are adenoma. And what is the characteristic histology of all these adenoma? They will be showing you dysplasia, right? So dysplastic changes will be characteristic histological finding of all these adenomatous polyp, right? So now you can see there are three types of the polyp: tubular adenoma, villus adenoma, and tubulovillus adenoma, right? So tubular, tubulovillus, all these adenomas are there, right? So now in this case, what I have shown you, this is the most common type of the adenoma, right? And common site is also the sigmoid colon. So most common site sigmoid colon. See, for all of them, all these adenomatous polyp, tubular, villus and tubulovillus, all of them is having same most common site, that is the sigmoid colon, right? Now the difference is you will see mushroom like glandular proliferation with stalk. Can you see when I was showing you? So that time also I shared, can you see the shape of biopsy? It was looking like a mushroom and there was a small stalk. So you can see there is a mushroom like appearance of the gland and there is a small stalk. So that is called tubular adenoma. Villus adenoma, what we need to remember, they have maximum malignant proliferation or transformation. So in all these adenomatous polyp, tubular adenoma, villus adenoma, tubulovillus, who is having maximum malignancy potential? Answer will be villus. Villus is having maximum malignancy potential, right? And they are having no stalk, that is why it is called as villi. So now you can see there is no stalk in this thing. So these are the villus adenoma. Tubular villus adenoma will be having mixture of the tubule and the villi, right? So mixture of the tubule and villi, you can see this is the tubule and this is villi. So this is the tubule and this is the villi. So mixture of the tubule and villi, that will be tubulovillus adenoma. Right now, this is the picture which I have shown you. You can see there is a complex branching of the gland. So as I said, there is a tubule. So these are the complex branching of the gland in the form of tubules, right? Mushroom like appearance. And now you can notice this was the area which will be corresponding to the stalk region of the gross examination, right? So this is the tubular adenoma and you can see there are so many tubule like glands are present, right? That is what we have to remember, right? So that is the complex branching of the tubular gland, right? Right, villus is the villain. Yes, villus is the villain. That is how you can remember. So now you can see this is the finger like projection, right? So now you can see finger like villi are present. That will be the villus adenoma. Now you can see this is the finger like villi. These are all finger like villi. So when you find finger like villi, so that means it is a villus adenoma, right? Now look at this. Now you can notice in this beautiful biopsy there are two areas. Number one, right? So this is the number one area. Just a minute. Right, so number one and number two, there are two areas I'm showing you. This is number one and this is the number two. In this area you can see there are tubular gland. Can you notice these are like tubular glands, right? Complex branching of the tubular gland. So these are the tubular adenoma, and now you can see these are the finger like branches. So this is the villi, right? So this is the villus adenoma. So in the same individual, when you find the tubular also, villus also, so this will be called as tubulovillus adenoma, right? Is it clear? So tubulovillus adenoma, this is the tubule like structure, and villus finger like structure, both are present. So this is the tubulovillus adenoma. Now come to the next question. 19-year-old man is advised to see his physician because of the genetic screening has been detected a disease in other family members, right? On physical examination, a stool sample is positive for occult blood. Colonoscopy is performed, followed by colectomy. Figure is shown in the gross appearance. Now you can see this is the gross appearance, right? So in this gross appearance, right, and the mucosal surface of the colectomy specimen, microscopic examination shows these lesions are having tubular adenomas, right? So these are having tubular adenomas on microscopic examination. Molecular analysis of this patient's normal fibroblast is most likely to show a mutation in which of the following? So which of the following mutation will be present in the normal fibroblast of this patient? So that is the question. So what is your answer for this question? Right, so for here I am getting the maximum correct answer, right? Right, so first answer I have got from the Manu again. So this is the you see 19-year-old man, right? Now physical he's having screening has shown a disease in other family member also, right? Physical examination stool sample is positive for occult blood, right? So that shows that they are having risk for the malignant transformation, right? That is why colonoscopy was done and colectomy was done. Colectomy specimen is given, and you are seeing so many small adenomas throughout the areas. So this is the familial adenomatous polyposis coli, right? So familial adenomatous polyposis type of, this thing, and they will be having APC gene mutation. So this is the right answer. APC gene mutation will be present in them, right? So familial adenomatous, because family members are also affected. Familial adenomatous polyposis, these are small tubular adenomas, and they will be positive for APC gene mutation, which is commonly seen in FAP disorders, right? MLH1 is the, it is seen in the, it is the mismatch repair gene, right? Mismatch repair gene, and they are associated with the HNPCC, hereditary non-polyposis colorectal cancer, right? So there will be not this kind of big nodules which we are seeing here, right? And KRAS is for adenocarcinoma. So it is not an adenocarcinoma. You are not seeing any kind of thing which is suggestive of the adenocarcinoma at present in this specimen, right? NOD2 mutation is present in the Crohn's disease, right? This is present in Crohn's disease. So answer is APC gene mutation, right? So remember, familial adenomatous or familial polyposis syndrome, right? Familial polyposis syndrome, which will be running in the family, or hereditary disorder. They are of two types, right? So they are familial adenomatous polyposis and hereditary non-polyposis colorectal cancer, which is also called as Link syndrome, right? So first we will talk about familial adenomatous polyposis, which is an autosomal dominant disorder. APC gene mutation will be there, and on examination you will find more than 100 colonic polyp will be present, which was shown in this picture also, right? It was appearing to be more than 100 colonic polyps was present on the gross examination, and they have 100% cancer risk after the age of 30 years, right? HNPCC is having mismatch repair gene, and that will lead to the microsatellite instability. They have an increased risk for the breast cancer and endometrial cancer, right? Now I want to tell you some of the important clinical finding which you may find in the familial adenomatous polyposis variant, because familial adenomatous polyposis, as I said, they are having association with the two important syndrome, Cowden syndrome and Gardner syndrome, right? Cowden syndrome and Gardner syndrome and Turquod syndrome, right? Gardner and Turquod syndrome, these are the two syndromes which are associated with FAP. So whenever we see familial adenomatous polyposis, as I said, they are having two important syndrome, Turquod syndrome and Gardner syndrome, right? Apart from this, whenever you are going to see ophthalmological examination of the young patient, suppose you are seeing a young patient and you are finding ophthalmological examination of the retina is showing you like this, right? So these are the retinal pigment hypertrophy, right? So retinal pigment epithelial hypertrophy, right? So this picture is given along with the polyp, right? So this is how question can be asked in your exam also, or you may come across with this kind of clinical scenario in your life also. Congenital retinal pigment epithelial hypertrophy will be seen, and that is very commonly associated with familial adenomatous polyposis, right? And more specifically, they are having association with the Gardner syndrome, right? More association is with Gardner syndrome. So this pigmented layer is having more thickness than the normal, and that is why you can see these are the areas which are looking like this, right? Dark areas are looking like this. So congenital retinal pigment epithelial hypertrophy is also associated with familial adenomatous polyposis, and in familial adenomatous polyposis, which one? Gardner syndrome is more commonly associated with them, right? Now you can see this is the so many polyps are present on the surface, and they will be usually more than 100 polyps, right? More than 100 polyps on the mucosa, right? Now you can see on the biopsy, right? We can see these are the normal areas. But now if you look at this area, can you notice hyperchromatic, or nucleus is more hyperchromatic, that is they are looking more basophilic. So these are the two important tubular adenomas. So these are the two adenomas foci which we are seeing, right? So this is how familial adenomatous polyposis, because see, these are corresponding to the small nodule which we are seeing on the cross examination, right? So this is how you are going to see adenomatous polyp like this on microscopic examination, right? Now the next question is osteomas, adenomatous polyp and periampullary carcinoma of the duodenum is seen in which of the following? Tell me what should be the right answer. Yes, APC is present on the chromosome 5. Osteomas, adenomas. Right, so this is the Gardner syndrome, right? So this is the Gardner syndrome. First correct answer I have got from Danish. So Danish has given me the first correct answer. This is the Gardner syndrome. Osteomas, GI polyp and duodenal cancer, these are associated with Gardner syndrome. Cowden syndrome we have already read, right? Cowden syndrome we have already read. Hamartomata syndrome, they are not having this kind of presentation, right? Peutz-Jeghers syndrome already we have read, they will also not have this presentation. Turquod syndrome, they will have brain tumor, right? They will be having intrusion of the brain tumor, medulloblastoma, glioblastoma. So osteomas, dentition problem, all these are findings which will be suggestive of the Gardner syndrome. So answer is Gardner syndrome. See, familial adenomatous polyposis, they are having association with Gardner syndrome and Turquod syndrome. Gardner syndrome will be having desmoid tumor, skin tumor, then dentition problem, multiple osteomas, and increased risk for the duodenal and thyroid cancer, right? Whereas Turquod syndrome will be having colonic polyp and CNS tumor. So CNS tumor can be medulloblastoma also, and it can be glioblastoma also, right? So now understood, Turquod syndrome will be having CNS tumor plus polyp. Gardner syndrome will be having desmoid tumor, dentition problem, multiple osteomas, and they will be having risk for the duodenal and thyroid cancer. So here I would like to show you the Turquod syndrome, how question can be asked in your exam, right? Examiner will be writing a history of the GI polyp, and he will be giving you a brain tumor specimen like this. So now you can see there is a pseudo palisading necrosis. So what is this? This is the glioblastoma. And here you can notice in this picture, if you look at this diagram, so you can notice there are Homer-right pseudo-rosette. Small round blue cell tumors are present. Right, so here you can see there is a small round blue cell tumors are present in this area. These are the differentiation, and round blue cell tumors are around them, right? So round blue cell tumors are around them. So this is the medulloblastoma showing you Homer-right pseudo-rosette, pseudo-rosettes, right? So Homer-right pseudo-rosettes are present here. So Homer-right pseudo-rosettes are present, and these are medulloblastoma. So glioblastoma, medulloblastoma along with the GI polyp, you should think about the Turquod syndrome. Turquod syndrome is also known as, please remember this is not given in Robbins, BTPS, brain tumor polyposis syndrome. So examiner can use these terms in your all India exam. So BTPS is another name for the Turquod syndrome, brain tumor polyposis syndrome. They have two forms, BTPS type 1 and BTPS type 2. Type 1 is because of mismatch repair cancer syndrome, or this will be having glioblastoma, right? This will be having glioblastoma. And remember, this BTPS type 1 is the original or true Turquod syndrome, because the person who has discovered his name was James Turquod. So that is why it is called as true Turquod syndrome. BTPS type 2, brain tumor polyposis syndrome, Turquod syndrome type 2 will be having familial adenomatous polyposis and medulloblastoma. So now you understand. So that is also one question you can expect. If you see glioblastoma, it is a BTPS type 1. If you see medulloblastoma, it is BTPS type 2, brain tumor polyposis syndrome, right? So this brain tumor polyposis syndrome, which is having medulloblastoma, this is also called as Kray's syndrome. So please remember these names which examiner can ask you in exam, right? Now I think this is the last question of the today's discussion. A 44-year-old female, increasing abdominal distension for the past 6 weeks, paracentesis yields 1000 ml of slightly cloudy serous fluid. Cytological examination of the fluid was showing you malignant cells consistent with adenocarcinoma. Molecular analysis of these cells shows MSH2 gene mutation, microsatellite instability. Medical history indicates that no major clinical illness, no surgical procedure. Sister was diagnosed with endometrial cancer and her brother was having carcinoma of the stomach. Which of the following condition is most likely cause of the patient's symptom? So tell me, what should be the right answer for this question? Very good, very good. I think microarray has right. Pseudo rosette can be seen. Pseudo retinoblastoma will be having true rosette. Raja Ravi, retinoblastoma will be having true rosette. That is flexor nerve intestinal true rosette. Right. So this is the mismatch repair gene MS2 MLH1. So it is not juvenile polyp, SMAT4, Crohn's disease, not 2, Peute Jagger syndrome, STK11. So what is remaining? Lynch syndrome, which is also known as hereditary non-polyposis colorectal cancer, and they will be having MSH2 gene mutation, which is the mismatch repair gene mutation, right? So family history is given. So in this question, if you look at carefully, see the age is 45-year-old, right? And the malignant cells were present. Mutation is MSH2 mutation. On clinical history, female, her sister is having what cancer? Endometrial cancer. So remember this point, that hereditary non-polyposis colorectal cancer, they are having association with the endometrial adenocarcinoma also, right? That was the NEETPG question in 2017, right? Endometrial adenocarcinoma is also associated with these people, right? So that is why your diagnosis should be Lynch syndrome, right? So now remember what is the Lynch syndrome, HNPC. As I said, MMR gene, mismatch repair gene mutation, as it was given here, MSH2 gene mutation, right? And this will create microsatellite instability, right? So basically these are gene repair defect, and they will have increased risk of malignant transformation in the breast cancer and the endometrial cancer. So that is why whenever you will carefully have a family history, you will find family history of the breast cancer or endometrial cancer. So in this question it was endometrial cancer, right? So I think I have covered nearly all the polyps which are important for you and for your exam, with the with all images and the presentation. So I think it will be helping you, definitely helping you in your upcoming exam, and you are going to get one question from here, probably that Peute Jagger syndrome, which is right now favorite of the examiner. But do not ignore all other conditions also, right? In the last, before I go, I will say good night to you all. I would like to say that during exam time, because this is the last 1 month, you might be feeling so much of difficulties, that you are having this difficulty, that difficulty, but ignore all of them, right? Because remember, difficult roads often leads to the beautiful destination. So you might be feeling difficulty right now, but if you persist with these kind of thing and try to fight against these thing, you will definitely rise. So now at this moment, what you should do, Homer Wright is in neuroblastoma, right? So you have to remember one thing, the basic thing you should not forget. Basic thing is, every morning you wake up early and try to revise your notes, right? Then read important topics. You cannot revise entire notes. So that is why I always say, solve 3 to 5 years of the question bank of the NEETPG exam, AIMS exam, PGI exam. Try to find out important topics, sort out them, try to revise these topics only from your notes, and make important topics which are very hard to remember, so that you can revise them in the last 7 days. That is also very important, right? During this revision part, because you are going to focus on those areas which are important one. In those important, there will be some tough one. So mark them and write it down so that you can revise them, especially in the last 7 days, which you are, then you should not forget after that, right? So that is the planning, so that in the last moment whatever you are going to read, you are going to remember for longer time. So the tougher things we are going to re-revise in the last 7 days, which will be helping us. So thank you so much to all of you, and best wishes for your exam. Good night, and I hope you will be writing in the comment box that if you need some special topic which I should come and cover in this question format. So I will coming up with those topics also in this last month.